Here are 5 chest x-ray findings that you gotta know for your CFRN and your FPC. Number 1, the most commonly asked thing about chest x-rays is ground glass opacities. Anytime you hear that ground glass opacities, or you're looking at a chest x-ray and it looks like somebody crunched up a whole bunch of glass bottles and then sprinkled it over the patient's chest x-ray, you can take it to the bank. It's ARDS, or acute respiratory distress syndrome. Number 2, attention pneumothorax. You're going to see a couple of things. Early in the tension pneumothorax, you're going to see a little area on the side of the chest x-ray where there's some space between the edge of the lung and the chest wall. Now, as that develops and get larger, you're going to see things like a deviated trachea. That's a super late sign, and we should be able to recognize this clinically and without a chest x-ray if the patient is severe enough to have a deviated trachea. Number 3, endotracheal tube depth. Look, we are not confirming placement with a chest x-ray. We're using waveform capnography for that, but a chest x-ray can give us an idea of the depth, and we should be aiming for 3 to 5 centimeters above the carina, or the armpit of the airway. My little cheat code is that I like to use is look for the clavicles, and the distal tip of the endotracheal tube should be just below where those clavicles come together. Next up is pulmonary edema, or a CHF exacerbation. There's a couple things you're going to see with these patients. You're going to have curly B lines, and it looks like these feathery little horizontal waves, particularly in the lung bases, that are demonstrating that pulmonary edema. Additionally, if this is a chronic CHF patient, you're going to see a wide cardiac silhouette. Normally, the cardiac silhouette takes up about a third of the diameter of the chest x-ray. In our patients with long-standing CHF, that they've got that big beefy left ventricular hypertrophy, we're going to see a wide cardiac silhouette, and it might take up to 50% of the width of that patient's chest x-ray. And finally, hyperinflation or gas trapping. This is super common in our patients with COPD. Normally, we like to see an umbrella-shaped diaphragm on the bottom side of that lung, but in these patients, that hyperinflation is squishing out the bottom of that lung, and they've got more of a right angle appearance on the bottom of those lungs, and that's going to give you an idea that this patient is mega hyperinflated. Can you spot these signs?